Guys, we're in the middle of a pandemic and these are trying times. It's hard on our mental health, our mental state. And this is why I love our sponsor today, BetterHelp. They're the largest online counseling platform worldwide. They change the way people get help with facing life's challenges by providing convenient, discreet, affordable access to licensed therapists. BetterHelp makes professional counseling available anytime, anywhere, through a computer, tablet, or smartphone. It's brilliant. Sign up today. Go to betterhelp.com/solvinghealthcare and get 10% off sign-up fees. Welcome to Solving Healthcare. I'm Kwadwo Kyeremanteng. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved. Quadcast Nation.
Look at you.
Oh, I'm going to preface this by saying, first of all, today was exhausting. But yes. It was exhausting. Couple, we doing our best to advocate for the Ontarians and Ottawaians of the city and talking about how we should be approaching COVID-19. So I actually asked my colleague, Dr. Tom Psarra, to come on today to talk about the latest news coming out of Ontario, that we're going into a further lockdown, what do we call them? Further restrictions. Basically, you're not allowed to leave your closet, and some other restrictions that are coming through. And yeah, I was just so frustrated. I needed a partner to discuss this on and talk about hope because, the MO that we've had on this show, on this platform, is saying positive. And I still think we could stay positive, but we got a bit of an uphill battle. So Dr. Tom Psarra, intensivist, internist, father of 3. I'm going to call him hockey dad enthusiast. Welcome back to the Quadcast.
Well, I feel very welcome, except there's no hockey right now, so I feel like a part of my soul has died, but that's okay.
Yeah, and you can't play it even. Are you allowed to play it?
No, I like watching my kids right now more than me kind of playing, but
absolutely.
Anyways, it is what it is, right? That's the least of our worries.
Yes, it's good. A little perspective. You're going to be coming a little bit of more of an optimistic angle than me. Okay, so tell me, what were your first thoughts when you heard Premier Ford come to the panel and tell us about the latest measures?
Okay, so no matter any way we kind of spin it, I know we want to take a positive view of life, and I know your motto is to try and you look at things the way you can control things, right? You can't control certain things, and we can control some things. No matter which way we face it, from a purely ICU hospital bed situation, and obviously we're ICU docs and we understand the sanctity of life and so we're in a tough position in Ontario from a perspective of what's going on, right? And all kind of forecasts, especially around Toronto and the surrounding areas, and many other parts of especially Western Ontario, look like they are heading towards difficulty from a perspective of ICU beds, and also long-term care homes have been significantly impacted. I think 100% of people agree with that. I don't think there's discussion with regards to where we can do things differently with respect to or think about it differently. Unlike our neighbors in the South, I think the general consensus, I think 99% of the public understands. We're not having the kind of same discussions as I think our American colleagues have, where they had to essentially kind of convince. The narrative was to try and convince the public that there was a problem, to many parts of the degree. And then instead of having conversations about how best to kind of look at this as a holistic approach, which I know you're an advocate of, people started getting, two camps, right? Mask, no mask, open, no open, Jon Snow declaration after the Great Barrington Declaration. I mean, it was almost kind of like Star Wars, right? Like the good and the evil, whichever way you wanted to look at it from whose perspective. I don't think we've had to fight that same battle. I think our population and our, the general population and the medical population, if you'd like to call it that, has had a much different approach. So I don't think we've had to battle that. So I think what we're here to do a little bit today is kind of like discuss that. So where are we here in Ontario from my perspective? This has been tiring for everybody, right? And we've kind of done the yo-yo thing for a while. Kind of shut down, locked down, not locked down, what have you. And to be very honest with you, I don't know how I kind of feel today, right? Like I've had a lot of mixed emotions with regards to things. I think from my standpoint, I think I'll say a few things. Number one, I don't think it's easy being a politician, no matter where you are in this world right now, because I think with social media and I think with everybody's different opinion, people are siloing in camps. And I think that's one of our biggest problems. I don't think there's respect in differing opinions. I'm seeing more and more of that in social media. And that concerns me, even amongst academic kind of discourse. And so where we are today, I think we, in some sense, haven't dealt with many of the issues that cause COVID spread.
Preach.
Pardon me?
I said preach. Like I'm
agreeing
with you.
We're in a state of moralization right now. There's some much smarter people who are into philosophy, and I dabbled in it a little bit in undergrad, and I enjoyed kind of reading books like that. But we're moralizing everything right now, from CEOs traveling to taking your dog on a 1.1 kilometer walk. I mean, I understand the importance of what I said first, right? There's an essence of, and I agree with that, leadership and everything like that. But we have to be careful not to extend it to, seeing some kids playing hockey at the park, like four of them, and then calling their parents up and calling the principal and the like. I think we have to be careful as a society, right? It's a bit of a slippery slope.
I think legit we're at risk of that, though.
Oh, absolutely. No, absolutely. We're like, and part of it, I think part of it's a lot of it's understandable. Like the one thing I'll preface everything that I'm going to say here today is that I'm looking at this from an academic / I'm not looking at this so much as an intensivist, although I'll tell you, we'll discuss why I think we are entitled to our opinion in this situation. But, I understand why society's here, right? But people are frustrated. People get their news from a lot of different angles. I think there's been a lot of poor quality news, to be very honest with you, with regards to the way things are portrayed. We haven't had a chance to discuss kind of like issues like long-term care in depth. We haven't had time to, or, you don't see that platform, in my opinion, right? Like there's 5-minute interviews, 10-minute interviews, but to actually kind of, every day I turn on the media and I hear the death toll, right? And that's draining to people, right? I mean, I'm an ICU physician. I respect life. I get it. I've made it my life's passion to try and save lives. But I think the way you portray things, the way you actually, when you do that, people just get emotionally tired, right? And they feel like they don't have an out. And I think we have to be careful, because then, we don't have a cohesive kind of approach to this from a federal level, right? Like, I'm not trying to talk badly about federal, provincial colleagues or anything like that, but what I'm trying to say is that there's no one kind of robust kind of approach like you see in some countries, for example. It's there's a lot of bureaucracy in this approach, right? There's a lot of provincial leadership that then doesn't agree with federal leadership, and you're seeing this right now with the vaccines, right? They're politicizing it, right? Both sides, right? And I think, they're spinning, right? We don't have enough vaccine. Yes, you do have enough vaccine. and people get tired of this, right? And so the way you want to control it as a human being, in my opinion, is you start trying to have some control over the craziness that is going around you legitimately. And then what I think people do is we're at the stage now where the way we're controlling things is by moralizing everybody's behavior. And I don't think that's the right, look, I did it at the beginning, right? I have a poor neighbor of mine who's a good friend, and I laid it on thick to him. I think it was in April or March when I saw something, I think, one of his kids playing or something like that. I apologized afterwards. I was wrong. And that's how I let out my frustration when I was overwhelmed. Right. So I think we got to be careful about that. That's all. Those are my 2 cents about that.
Yeah. There's a lot there. Like, one thing I do want to say is, and just a point of emphasis is, are we approaching this problem? Like, are our measures addressing the real issues? And this is where it's killing me. Like, we're watching Ontario, Quebec, for example, they're doing all these added measures, added restrictions, and it's not moving the needle. You know what I'm saying? And no one's asking themselves, like an intellectual, and say, yo, why isn't this working? Maybe we need to switch gears. Maybe we need to pivot and approach this completely differently.
So let me answer that in a two-part essay.
Do it.
All right. The first part is, I know you and I have talked about this when we were rounding at one point, because what I said is, what gives me and you as ICU physicians the right to talk about public health or policy or what have you, right? As you know, I'm dabbling at possibly doing a master's in public health, and I was talking about that with you about a couple of weeks ago, because it interests me right now at this part of my life. Not that I've done 13 years of university, but why are we kind of have a different angle? And then I'll answer the second part. So I think we have a very unique set of skills. Number one, we deal with life and death every single day. So high stakes, right? A lot of our decisions are based on high stakes. 2, we're specialists, but we're kind of not, right? We're specialists in that we've done 2 extra years after our internal medicine or our surgical fellowships or what have you. And so we know how to ventilate, we know how to intubate, we know how to do all that kind of stuff. But at the end of the day, we're quarterbacks in the ICU, right? So we have to take different kind of opinions from, sometimes 3 or 4 different specialists, apply it to our patient who has varying degrees of stability throughout the day or week, at times balancing their needs, their rights, their, everything that, everything that's them as a human being and their families, right? And then also what's going on in your overall ICU as a unit, right? And so you're trying to take all those things, and then you're trying to balance it to try and make a decision, multiple decisions throughout the day, to affect a very high risk outcome, much like COVID from a population level standpoint, right? So we're used to kind of looking at this and saying, no, I kind of don't agree with this. I kind of don't agree with this, but let's try this. And that's actually very important, I think, because we are able to kind of look at things kind of from a dispassionate view sometimes, and kind of say, let's calm down, let's kind of look at all the evidence. And then what we do is we make a decision, and we see within 10 minutes whether or not it's working or not, or an hour later or the next day, start an antibiotic, start a different medication to increase the blood pressure, take a different avenue, get a CT scan. But if things don't work, right, what do? We don't just sit there and kind of like give the same antibiotic and give the same antibiotic and give the same antibiotic and then say, well, it's ceftriaxone. And I'm not going to give 1 gram, I'm going to give 2 grams. God forbid I give 3 grams. Do you know what I mean? So, at miropenem, right? Okay. So the neutron bomb kind of thing, right? So the issue that I'm trying to say is, yes, I think we are capable of looking at this. And of course we're not there's a million stakeholders out there. And so they should we're just one person who has our opinion, and they should have a right to their opinion. And
let me add to that too, Tom. We base our decisions on incomplete information all the time.
All the time.
All the time. You don't know exactly, someone's crashing. You don't know what the cardiac function might be like. You don't know what's driving the infection, but you make a call based on all the information in front of you, and then you adjust. If your plan A is not working,
right,
if it doesn't seem like you're about, and then you adjust. There is nothing like that happening in Ontario.
Yeah. So so this is what I would say about that. Yeah. And with regards to adjustment, this is a real tough situation because it's almost like we have the same infection on the same patient in different parts of the world, but everybody's got a different approach to kind of dealing with this, right? And everybody, just like as in medicine, everybody thinks their approach is the best way. And then the way we deal with this in medicine is we sit in journal club, right? Mm-hmm. And we dissect a paper into multiple ways. And there's a person who's got a master's in epi who looks at it one way, and then there's me as a clinician and educator who looks at it as another way, and then there's somebody else who looks at it another way, and then we argue. But we all eat, Greek food while we're arguing. At least a couple of years ago. From
Kuala Lumpur as well. From Kuala Lumpur.
But you understand what I'm trying to say? But that's expected, right? That's what we do. But we're doing this live now. We're doing this on Twitter. We're doing this everywhere, and we're doing this. Actually, society is getting a glimpse of what we do on a monthly basis or every week basis in Journal Club. Journal Club being like we look at a study, and we argue whether or not we're going to give this drug or intervention to a patient of ours. And this amount of disagreement is normal in medicine, right? But when something's at such high stakes right now, the public is looking at us and saying, "Oh my God, you guys don't know what you're doing," right? I mean, this is the way I look at it, because they're seeing us kind of debate whether or not, at the beginning, whether or not anti-malarials were working and yada 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 yada, right? But this is the nature of science, right? Science doesn't take 1 week to figure itself out. We've had some amazing kind of recovery trial and what have you that has shown us amazing things, but those take time. Vaccines have been an absolute wonder right now, but those also took 1 year, right? Which has been incredible. So, going back to what, kind of what you were saying about everything, right? We do look at this in a different way. This is science playing out. And when it comes to Ontario, what I will say is this. What I will say is that I don't propose to have like the answers to all of this. That's the number one thing I can say. But I do respect everybody's opinion, and I do give everybody their say, whether or not I'm reading or talking to somebody, and I've talked to a lot of people about this. And I think that's where we need to go, because I think what's happening now is advocacy is becoming siloing. And advocacy is starting to become, I believe in this, and if I don't want to hear you on this side, I will tune you out, or even demonize you a little bit with regards to things, right? And like you don't know what you're talking about. I really, it's not like I'm going to take the Canadian stance here, but I'll kind of go in the middle of a lot of these things sometimes. And what I will say is, what I have seen from everything that I've read from both sides, I hate saying that with regards to COVID, but that the people who are more for lockdown and the people who are more for kind of like a very general kind of mitigation approach is, number one, I think we're in a law of diminishing returns right now with regards to lockdowns, in my opinion, right? I think that we have to take society's appetite for decreasing their social expenditure, right? All of us need to kind of like feel like we're human beings, right? And I think people have done a tremendous job, to be very honest with you, across Ontario, right? Our Google numbers may not be perfect, all that kind of stuff, but I think people need a pat on the back with regards to this, including myself, including you, including everybody. Everybody kind of needs to kind of prop each other up and say, you know what, under the circumstances, I think we've done a remarkable job as a society and as citizens, right? So I think rather than looking at the 5% that maybe quote unquote flouting some rules and so forth, I think the vast majority of people have really tried hard. The other thing that we're seeing is workplaces are becoming a massive place of spread. And the burden of this illness, as we've seen in our intensive care units, has come from people who unfortunately are marginalized, racialized in our communities, and don't have a high income. People who are essential workers basically have to go to work. They have to take public transit, and they have to have exposures, right? And so when it comes to workplace outbreaks, manufacturing, I was reading a stat the other day, I think in Toronto, as being like 40% of their outbreaks, as opposed to restaurants and bars and so forth. Now, I tend to believe that restaurants and bars also have obviously, in my opinion, have spread anytime you have people in a place. And I think it's hard to document that the way we're kind of going about it. But I also think that we have to kind of look at where spread is happening for sure. And definitely, if you look at warehouses, if you look at manufacturing, if you look at construction, you look at a lot of places where people really have to go and they have to make a living. And if they don't show up to work, they don't have the same type of benefits as a lot of other people.
They don't have benefits.
Well, exactly. No, they don't have benefits. You're right. This is what I'm trying to say. They have to go to work, right?
Like, and just to illustrate this to people, I've made this point a few times. Like, a lot of these people that are on right now, we're allowed Zoom life. Okay, we could work from home. A lot of us. Not everybody, obviously. Like if you're, a restaurant owner, store owner, business entrepreneur, like these are different. But especially when I think of Ottawa, a lot of us have the privilege of staying home and still earning a living. But these people, the marginalized communities, the essential workers, even to get tested, you need to take time off. Okay,
right.
You need to get time off, and that's less money in your paycheck. Okay, like this is income not coming to your family. Then you get. Say you are positive. Now you got 2 weeks off without pay. Then I'm just read someone threw this down on my Twitter the other day. There's people that if you're off for 2 weeks and they know you got COVID, then you can't come back to work in some of these environments.
Sure.
Like it's crazy. So like I've been preaching all day in the news today. Paid leave. You need to be able to support our citizens when in time of need like this. Otherwise, you're not taking you're not putting a dent in the problem. And we know this is a problem. And it's been clear from the get-go. Look, I mean, without getting into specifics, when you walk in the ICU, the demographics, it's like, I'm not exaggerating, guys. Like, it's predictable. Not only how, like, there's exceptions always, like everyone's going to give me the one-off or whatever, but older, comorbid, often in the multi-generational home, someone in that house is an essential worker, okay? And it's like, what would you say on a percentage, actually, if even just to give a...
Me, 80.
Yeah, like...
From what I've seen.
Exactly.
So this is what I see. This is what I see in the ICU. So multi-generational home, smaller living confines when you look at like...
high rises, example, for sure.
Yeah, high rises, smaller living space. Okay, more people within that living space, multiple areas of work in that living space, people who take public transit to go to work, people who can't take time off, people who, from a work perspective, basically if they were to tell their employer that I can't go to work, that there's a significant pressure to end up going to work. Remember here, we're not talking about Ebola, right? Like you get Ebola, you can't go to work, right? you nobody's going to grab you and say you got to go. Like we're talking about an illness where 25% of it is transmitted when you're asymptomatic, right?
Yeah, like some of these guys will look.
Yeah,
like
exactly. I've got the sniffle. So you and I have the ability because of our income, okay, to basically take a week off work and annoy, I know our colleagues basically and say, okay, you got to work. We've all had that phone call. I've done it to you. You've done it. I mean, we all do it to each other. But aside from that small little thing, we don't have to go to work. So if I wake up tomorrow with a stuffy nose, I go, you know what? This could be COVID. Okay. Now, when you're living paycheck to paycheck, okay, and you're supporting your parents and you're 40 some years old, and you're living with 8 other people in the house. Now you tell me how easy that decision is going to be for you to start thinking, quote unquote, beyond yourself and start thinking about, 5 generations of virus later.
Yeah.
You're thinking about the food on your table. End of story, right?
Yeah.
So I think it's very easy for us, okay, or a lot of people who, in Ottawa, let's face it, right? Like Ottawa is a government town. Ottawa is a high-tech town. Ottawa doesn't have a massive public transit system. It's very spread out, but it's not like a, metro, or it's not, like a subway system like Montreal and Toronto are, right? The amount of exposures that you get in an Ottawa setting, like we have a very protective effect in Ottawa, right? It's not all about us like being better than people in Toronto or Peel at isolating or having some moral superiority. And I'll extend that to my family who's out east, right? They're not somehow better at doing this stuff than we are to some degree. I mean, I think to be honest with you, I think their provincial leadership has been able to have a stronger, kind of tighter border control kind of thing. But in essence, I don't think we're that much different. I think there's a lot of luck in this. There's a lot of, like, Ottawa's lucky in the sense that we have a social demographic, whatever you want to call it, workforce that is very protective, right? On the most part, we don't have massive manufacturing here, right? If we had massive manufacturing here, if we had, situations like, for example, like in Vaughan, like Peel, right? You're gonna have situations where all of those little things build up and then they cause bigger events, right? You have a manufacturing plant with 400 people, right? If 50 people there get COVID, and then they're all in multi-generational homes, as opposed to Sweden, where there's 43% of people who live by themselves, then what ends up happening? Well, of course, you're going to spread it to 20, 30% of the people you live with, depending on, in a smaller home, smaller high-rise kind of like apartment building. And then all of a sudden, what ends up happening is boom, 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 it spreads, right?
And just to reinforce that point too, Tom, like you said, we get the sniffles. Just write this out with me for a second. We get the sniffles. We get tested right away. You tell your wife and your kids we probably should stay home or whatever. And so when you think of the downward spread, secondary spread, right? Maybe your wife got it because you were living in the same quarters or whatever. Assuming your marriage is going well, you know what I'm saying?
Oh, it's fantastic. I'm married to the most lovely woman in the world, and you know that.
Absolutely. Julia, yeah, you could second that. And then, but like in that exact opposite scenario, when it's a multi-generational homes, the Amazon employee or factory worker, they're not getting tested. It's propagated like that. The wife easily could be in a similar situation where she's bringing it to if she's a personal support worker, she's another essential worker, that spreads that way. And then the grandparents end up in the ICU or hospitalized because they're in that multi-generational home, and it just propagates. It just propagates. And what it comes down to, people, this is why I get so frustrated with the Fordisms, the Elliotisms coming up and saying their thing, is because we are not addressing this at all. Everything you're talking about, schools, masking outside, borders, like provincial borders and all that stuff, does not address this. Okay, and this is what's driving me nuts, is that you are like, I forget these expressions, like I mix my metaphors all the time, banging your head against the rear view mirror.
What are you? Sorry, I need a bit of ouzo for that. No, it's water.
Yeah. But and this is it, and it's being met with judgment. People are judging people, saying, hey, this city's not doing their part, all these people not doing their part. It is the nature of the beast. We haven't created a solution for them. Okay, I just saw somebody even brought up on the text about rapid testing. Can you explain to me, like I'm 8 years old, why this bad boy doesn't exist?
Well, I think the problem with rapid testing. So rapid testing with regards to, like, I'm not Michael Mina, who I follow quite closely. He's an epidemiologist at Harvard, and I tend to agree with him. Right? I think in essence, the PCR test that we have right now is a phenomenal test, in my opinion, for patients that we see who we need to know whether or not that patient has COVID, because it affects our treatment of that patient.
Sure.
Do we give dexamethasone?
Super sensitive.
Right? Exactly. Super sensitive.
For a hospitalized patient, yes.
For a hospitalized patient. And I would argue nowadays, with monoclonal antibody treatment, I mean, obviously it's the availability of that everywhere is different and yada, yada. Okay. But but I would say that in a lot of areas, it's important to know what you're dealing with. Are you dealing with RSV? Are you dealing with influenza? Are you dealing with COVID? Okay. But where rapid test is, where I see it beneficial is to kind of in areas where you need to know whether or not you're infectious, right? So for your listeners in here, let's go over Muge-Sevic's kind of curve, right? Because this is very important, because even a lot of people within healthcare who are incredible, incredible people, are still in the mindset that the infectivity period sometimes is very different than what it really is, at least for the variants that that we know about prior to that B117. Okay, so basically, we're most infectious pretty much 1 to 2 days before our symptoms, right around where our symptoms start, right? This is very different than SARS, where it was like 1 week out. And this is why hospitalized patients were transferring it to their doctors and healthcare workers. So the day or two before, like, you don't even know that you're like, you don't even know you have COVID, right? Or I should say infected with SARS-CoV-2, but you understand what I mean. You don't know that you have COVID, and yet you're like half an hour before you get the sniffles, you are maximally infectious, okay? And then after you're basically, you get symptoms, then you're basically really infectious for about 5 days, right? And then it goes down significantly until you're really not infectious 10 days after your symptoms. Important for people to understand that. Think about like the uphill battle we have, right? So think about your test and trace uphill battle that we have, right? Mm-hmm. Unless testing and tracing happens like very quickly and very well, right? In some parts of the US, you were getting your test back, like I did in late March, 14 days later. Like now it's not 14 days, but let's say you're getting it 5 days later, right? You're supposed to isolate, but then this person who wants to isolate is basically, they get their test, they isolate, but they're getting their test results 4 days later. Are they not going to work for 4 days? I mean, I understand the frustration when somebody goes to a bar right after that. Okay. I mean, I'd have words with that guy too. Okay. But the reality is that's one person, or that's two people. That the vast majority of people who have this kind of issue are people who just need to make a living.
Right. But I guess where I see the rapid test personally, and I apologize because my wife was trying to contact me at the same time. Yes, Kathy, I'm doing this. Love you. And maybe you addressed this a bit ago, but just on the asymptomatic, I see it as a good asymptomatic tool. Do you know what I mean? Like prior to, because if you got symptoms, yes, go get your conventional PCR. Like, it's easy. But if you're one of these factory workers, or you're going into a long-term care facility and you get your antigen test prior to coming, to me that makes a lot of sense.
Well, what Dr. Mina has talked about is the difference between a diagnostic test and to look at whether or not you are infectious.
Right.
And so
because the PCR for sure is not going to tell you whether you're infectious or not.
No, I mean, you could be 10 days out from a asymptomatic infection, be PCR positive, have RSV, and then test positive, right?
Yeah.
You could you could have a situation where your PCR, you're not very infectious whatsoever. Your CT value is 40 or whatever, really high.
Cycle threshold.
So I mean, I love the PCR test is the gold standard that we have right now, right? That's as good as it gets. But I think the problem with the PCR test is that there's only a certain amount of capacity, right? And so if you're looking at, we're not all the NHL, right? Where people can get a PCR test and find them like 1 day before they become symptomatic and get them off the ice basically a day before or 2 days before they could actually be infectious. That's not real life for most people. So the worry, I think, is that traditionally the way most regulatory bodies have kind of passed on these tests, said yes or no, has been, their sensitivity, right, with regards to that, and they've been used mostly as a diagnostic test. But when is that threshold in society going to be to allow a few kind of false negatives to go through in a situation where somebody may infect somebody else? I think sometimes perfect is the enemy of good.
That's exactly it. This is exactly my point. You're not going to be perfect, and it's better than what we're doing now. Like
right now we're flying off. Like, so just look at what we're doing now. Right now, people are doing temperature checks, right? So you and I know that temperature checks, in my opinion, mean almost absolutely nothing.
They mean nothing. I think even I can't remember what paper I'm thinking of, but fevers were actually way less of a symptom than you think. It was like, I can't remember, like even myalgia was ahead of fever.
Oh, I read somewhere where somebody was said, just smell a flower as a test before you go into a store.
But
and if you can smell it,
that's got to be ultra specific though.
No, but you understand what I'm trying to say, right? Like, I guess what I'm trying to say is where we're at right now is the honor system, right? So my kid, two of my sons, I know I've said this before, play hockey, right? So they have great protocols, but they do as well as they can, right? It can't be perfect, because what you're getting at is you're looking at a symptom screen protocol. So have you been out of the country? Do you have this? Do you have this? But again, if you're talking about a 9-year-old or a 10-year-old child, many of them are asymptomatic, right? So if you were to say they were going to go into a dressing room with somebody else for 30 minutes of prolonged contact, then you need barriers, masks, But if the whole point of that screening questionnaire is to try and limit your exposure to come into a setting, whether it's workplace, whether it's sporting, whether or not it's audience, whether or not it's anything, right? School, which is the highest up on my list. If you can have a rapid screening test that actually is added to that, right? I can't see how that could be worse than our baseline.
Of course not. And
it'll pick up students or participants that are infectious, no matter what. So if you have enough of a viral load, there's lots of studies that show this, by the way, and and if you have a high enough a viral load or low enough CT on a PCR, it will pick up the rapid antigen test will pick it up.
Yeah.
We can say if we put up our CT up really high, which we will see in the ICU as a positive test, perhaps a rapid antigen test will say will not pick it up.
Yeah.
The argument is that you're not as infectious. Okay? And there's people on both sides of that. Maybe it gives us a false sense of security. But look at what we have right now, right? So what we have right now is, do you have a cold? Do you have the sniffles? Do you have a fever? And do you have a change in your in taste? That's basically like, if you answer no to all of them, in you go, right?
Yeah.
So why not do that and a rapid test? Yeah. It's because perhaps it's legal. Perhaps it's the fact that, again, perfect is the enemy of good. That one person that you can show that passed through your screening, well, now you can say, well, you didn't really screen properly, and the moralism side, right? Mm-hmm. Whereas before, now it's a problem with a governmental approach. It's a problem with, and so then you might add a whole bunch of things. I don't subscribe to the point that it is a situation whereby we should scrap it just because it's
not perfect.
It's not perfect, and I know Canada's they're really trying. Like I've read through Health Canada's. I'm not trying, like I've actually read through their whole guidelines on this, where there's backup PCR testing and things like that, and they're trialing it at multiple different places. It's just that in pandemics, like Dr. Ryan said, right, with the World Health Organization, sometimes acting faster is better than taking your time with regards to some things. And I think vaccines and things like that, you got to be really careful. And I think they've done a great job, because I think, we have to basically make sure that people trust in the process and stuff like that. But when the only thing that we have right now is a questionnaire, right? And the tests actually look pretty good with regards to rapid antigen testing.
The ones that I read, it came out of Abbott. It was press release. The sensitivity and specificity were ultra high, 98, 99.
Yeah, so they're very high depending on what you're looking at, the CT thresholds. If you're going to compare it to PCR, where you have just a little bit of virus that you're amplifying, then they're not going to be as good. So that's.
I will still, just because I don't want to bore people, but like the other thing that I've read clearly, well, I shouldn't say clearly, is from a couple of these virology journals, was that if the threshold is that high, the likelihood that they're viable or infectious is low. You know what I'm saying? And yes, you don't want to miss out this shit, but in the era where we're pretty much treating everybody like they have COVID regardless in hospital, you do wonder where would there be that much of a downside to introducing rapid testing? And I personally, straight up, just because I'm a bit on the pragmatic side, I don't see the issue. Like, I see the issue, but I don't see the issue.
No, from a public health standpoint, I think it would be if again, I'm not an expert at this, but obviously I have medical knowledge and I know how to read journals, and I listen to multiple different opinions on this. I'm on the side of, if somehow people could do 2 or 3 tests a week because they were scaled economically, that it would take you 10 minutes in the morning while you're brushing your teeth or what have you. Just look at a target population like schools, for example, right?
Yeah.
Then I think you pick your target population where it's very, very important, and you trial it like that. I think if you can kind of do it to that effect, but we just don't have it's not scaled economically so that it costs $1 a day, right? Right now it would be.
I read anywhere from 5 to 15 is the range I've seen.
And even in the U.S. too, there's actually an at-home test right now that I forget the name of it. It starts with an EL something, but that's actually approved by the FDA. But anyways, I don't want to get off too much off topic, but that's where we might be, like later.
You better be. The other thing I think we should touch on, just to get to solutions, because once again, long-term care is an issue. But luckily we've been able to vaccinate some of our, actually a good portion of long-term care associated people. And surprisingly, what I was reading and hearing about some colleagues, that like up to 50% of long-term care staff were saying like, I'm not ready for that vaccine, which I was actually quite shocked at. But my question for you is, when you think about who should be getting it next, you know what I mean? Like, what comes to mind off the top of your mind grapes?
Me? Age.
Yeah.
Age. Yeah. That's, it's 3-letter age. I didn't even think you were going to ask me this question, and it just this comes out very easily to me. If we're seeing right now, I think the first part of vaccine rollouts, actually from an ethical standpoint in Canada, is actually being quite easy. Of course I follow Twitter, and I know that there's been, over the last couple of days, there's been some concerns, but which I'm not going to get into right now. It's obviously hard to go through that. And I've even volunteered with Ottawa Public Health with regards to whenever I'm not in the ICU the next month, which will probably be never, because I'll probably be there all the time. But to vaccinate, I'm saying. But the issue is going to be, the harder part is going to be the second phase, right? The harder part is going to be March, April, whenever the first kind of phase rolls out. The U.S. right now, in my opinion, from an ethical standpoint, is a monumental failure with regards to vaccine distribution, right? So I'll go on record saying that. I have no problem saying that, in my opinion. And so I hope we don't follow their lead, which is, money and influence creates opportunities where it shouldn't. I think the next situation would be, where can you make a biggest dent in the morbidity and mortality of this awful disease, right? And if you look at anything, I know we've talked about comorbidities like diabetes, and we've looked at a whole bunch of other health factors, cardiovascular disease. But the number one predictor, no matter how you look at it, is with regards to a differential factor from very low morbidity, right? So in children, right? So if I found out that one of my children had COVID, I'd be like, okay, right? Yeah. Like, they have the flu, they have RSV. I'm talking about my 9-10-year-old kid. Okay, I'm not talking. I want your comments, please, about a 35-year-old, I get it. It's worse. COVID's worse for a 35-year-old than the flu is. I get it. But I'm talking about a 9 or 10-year-old kid. We all know the data. We all know the Swedish data. No deaths, during school. I mean, I don't want to get into all that, right? Yeah. But once you start getting into like 50, 60, 70, 80, 90, it's a logarithmic jump, right? Like it's like every decade, just like it's not a linear curve with regards to mortality. So if you conceivably, we've seen patients conceivably, they're living at home at 90, right? They're not in long-term care. They're not in a retirement home. They drive their car. You go vaccinate that person ASAP, right? You vaccinate the person who's in their 80s. The problem will be, how do you tease that out? Like, how's it actually going to work, right? Is it gonna be like, okay, family docs are going to look at this, or public health is going to have a record of everybody who's 80 and above? Again, you don't want perfect to be the enemy of good, right? But if it was up to me, I would say, hey, buddy, I would say age
Hello.
is the number one thing.
What's up, buddy? Just a little bit more, buddy. And then close the door, too.
Hello, how are you doing?
I'm doing fantastic.
Yeah, that's Tom.
Fantastic. My name's Tom.
Oh, hi, Tom.
What's your name?
Marlo.
Marlo. Marlo's very happy. He's jumpy. I love it.
This is it. Peace, brother. Hey, can you close the door? Sweet boo. Thanks, buddy.
So I don't know if you agree with me, but I think age is huge on the list.
Yeah, without a doubt, age. And there is a practical aspect to this that I wonder about. Like, I still think the 70-year-old that is not on any medication compared to the 58-year-old that is diabetic and hypertensive and obese is worse off. But at a practical level, I don't know if you could really hammer that out in terms of attacking the people with the comorbidities first. So once again, we talked about perfect is the enemy of good. I would definitely be able to live with going from age downward. You know what I'm saying?
Well, let's look at it another way, right? So Canada just signed off on another 20, with their contract with Pfizer, right? And initially, they have up to, I believe, 73 or 78 million, right, total doses that in their initial contract, and so they have a clause that they can buy another 20 million. So they opted in on that clause today. So they're getting another 20 million. So 20 million should be from they should get 20 million between April and June. Okay. Let's say Johnson & Johnson comes back with EAU, so emergency use authorization, when I looked at the phase 2 data of Novavax, I was blown away, right? So, but we know phase 2 doesn't look like phase 3 all the time, right? And Canada has procured for Novavax too. Somewhere along the line, the best case scenario, I would say even a reasonably scenario, would be that we actually don't have to start, prioritizing as much as we had in the first phase, like first versus second phase. My hope is that it's going to be more of a logistical and bureaucratic problem as opposed to an ethical problem. You see what I'm saying? Like I think if you have 10 million vaccines within 20 million vaccines within a 3-month period, and you can vaccinate 10 million people, and Novavax, by the way, is one-shot vaccine, right? Again, Novavax will probably get EAU in the US by around April if they do get it, okay? Yeah. So let's say that does happen. The reality is that I think it's more of a bureaucratic / boots on the ground kind of like logistical problem as opposed to otherwise. I was really happy to hear that today. So the more vaccines we have earlier on, and I bet you we'll probably even get more and more, the reality is that whole kind of, okay, we're going to deal with 70 to 75 now. I don't think it's going to be as much of an issue, just because of the fact that I think it'll be able to be like, okay, everybody above 65, for example, or everybody above 60. And then you get those comorbidities, because it's very hard to tease out. Like, people say, well, my diabetes is more important than your hypertension. And I mean, I respect that from people, and it's a really hard situation. I've had to deal with chronic illness myself throughout 45 years at certain parts of my life. So I understand it, but the reality is that how are you going to tease that out, right?
That's exactly what, I'm with you there. The reason I do think it's worth the discussion is because this wave, and we see the projections, which is another topic, by the way, these projections for Ontario of catastrophic amounts of intensive care needs and so forth. And so, like, if we could vaccinate our most vulnerable, amplify that, or be it somewhat targeted, maybe that reduces the need for intensive care and for hospitalizations. I do think it is a bit of a pipe dream to be that targeted. But here's my question for you. When you hear those projections, I got asked this several times today, what comes to mind when you see that, our ICUs looks like we're going to be overrun and so forth?
What comes to mind is, you're probably not expecting this answer, 2003. What comes to mind is SARS. What comes to mind is the SARS report. And what comes to mind is governments in the past cutting healthcare. That's what comes to mind. I'm going to talk less about the modeling because I'm not an expert in modeling. There's a lot of bad models. There's a lot of pretty good models. I have a lot of respect out of U of T's kind of epidemiology for the way they've carried themselves with regards to how they're modeling and so forth. I respect that. And there's a lot of good people working there. The issue that I would say is this is, in economics, you always think of supply demand, right? And so we have 14.5 million people with 2,000 ICU beds, right? And so I don't blame this government. I don't blame any particular government. I'm not in the game of blaming people. But I think that when we get over this, we really have to look really hard in the mirror for one thing. We as a country strongly believe in a universal single payer health system, right? But we also don't like high taxes. And we also don't like certain things, right? I'm not saying I want to be taxed more, okay? I'm not saying that. But what I'm trying to say is that every action has an effective reaction. What I'm trying to say is that in 2003, when SARS came out, we had a lot of recommendations afterwards. And successive governments have made it harder and harder for hospitals to exist to a certain degree, right? I mean, you need capital, you need funding, right? And I think some governments have been very, very responsive to certain local needs, absolutely, 100%. But I think we as a society have to make decisions to say, okay, if we want a single taxpayer, like a single payer universal healthcare system, it can't crumble with pandemics, right? Because pandemics are going to happen. I'm not sure this is a 1 in a 100 year kind of scenario anymore, right? We have 8 billion people in the world and we travel by airplanes. And so we're encroaching on, other mammalian territories. There's going to be a jump of viruses. And at some point it's like playing the lottery and you're going to lose sometimes. And this is what's happened this time. We have the perfect combination of transmissibility and infection fatality rate. The infection fatality rate of this was 30%. We'd all be hunkered down. You know what I mean? It's at that margin where, people can take it seriously and other people don't want to take it as seriously. And it really complicates society. All I'm trying to say when I see those models, I'll answer it in two ways, is number one, I think we have to be very well prepared for the next pandemic, whenever that hits. In essence, have a backup plan when it comes to capacity, right? And we start thinking about it right now, right? Just like we have an army, just like we have, you know what I mean? Like armies don't go and fight every single day, but they prepare for that, right? It's basically taken Western countries and brought them to their knees. Literally, right? Like it's decreased our GDP. It's decreased our quality of life by a substantial amount. And we're all doing this to try and protect our healthcare structure. And there's a ton of, like, everybody's trying their best. CEOs, hospitals, admin, docs, nurses, everybody's trying their best. But we have to have a serious discussion after this and say, how did we get to a place in Western society where a pandemic is bringing, like, for example, now in the healthcare in the UK, it's literally stretching it to its absolute maximum, right? And so then what we don't want to see on our TV screens is people making life and death decisions. I mean, I know we make life and death decisions all the time at the end of CPR and things like that, but it's not the same as saying, okay, we don't have oxygen. Like, we're not used to that in Western, right? Like, we're not used to making those decisions, right? And so we have to kind of prepare for worst case scenarios, right? And I think that costs money. That causes that we have to make decisions about where we're going to take money away from to put money into this, because we have to be prepared next time so that it doesn't put us into like a situation like we're put into now. So what we're trying to do is basically save our healthcare system from collapsing. That's what we're trying to do. Now, are we going to get to that point? You know what? I actually believe that we're in a situation where things might get bad. I'm, you know, like I look at that modeling.
You
and
think like when you're saying bad, you mean Ontario in general or local?
Yeah. So I mean, I think, you know, I think politicians, I think, you know, epidemiologists, public health policy analysts. I mean, people who are making decisions right now are in a tough situation, because, you know, you and I are going to be working our tail ends off for the next 2 months, in my opinion. But I think that it's very indeed possible. I mean, I've looked at the percent rise, whether or not it's 3%, you know, per day on average. Hopefully this will be mitigated. We talked about all the factors that go into it. But could we get there? Absolutely, we can get there, in my opinion, right? Like, we're at 400 and some beds, let's say 410 beds right now in the ICUs across Ontario. I think one of the factors that we haven't played into this, which I think England, I think the UK, I apologize. So I think the UK has seen, is that exponential growth. The human mind can't comprehend exponential growth. Neither can my mind. It's starting to get better at it. But I'll put it like this for anybody who I'm just trying to explain exponential growth in the context of, it's like a locomotive, right? It looks like it's going okay. It's going okay. Okay, it's a big freight train. It's starting. And then if you kind of put the brakes on it early, it can stop, right? But then once it picks up steam, it's really hard to stop, right? And so this is what we're seeing with this. And we've seen this in Ottawa too, right? Like, we were doing really, really well, right? And then all of a sudden, you know, we were open and stuff like that. And then it just kind of started taking off. And then here we are now, right, in Ottawa. It's not anywhere near Peel or Niagara region, or, you know, but we're definitely at, you know, about 100 cases per 100,000 per, you know, per 100,000 per week. You know, and so, you know, I think that, yeah, it's one of those things where I think exponential growth has made a lot of people like me kind of look silly when I've been trying to kind of navigate my way around questions about whether or not we're going to end up somewhere or not, right? The problem is, you could be at 20% capacity and then in about 4 weeks be at 120% capacity. Yeah. That's the problem with trying to model these things.
Yeah. And I've similar to what you're saying, like, respect for where the numbers could go. You know, we've seen, my skepticism has always been, and we've seen these forecasts before.
Yeah.
And sometimes the less aggressive stuff at times could be accurate. The more aggressive stuff has, in my opinion, we've yet to see. But, you know, you got to prepare for the worst. And
doesn't mean you can't be positive, in the sense like that it doesn't mean you can't kind of rally the troops and be positive and kind of like try to look at the, you know, I mean, we can't all live in a sphere of negativity every single day. I mean, I'm not tone deaf, right? Like, there's people that I know who've suffered. I've suffered through different things, nowhere near, you know, but, you know, we've all had our trials and tribulations, and I'm not trying to be tone deaf. I'm just trying to say, I think it's important to try and get some, like, if I went to work every single day feeling completely overwhelmed, I got to take care of my mental health too, right? I got to be there for people. Yeah. I don't know if you're understanding where I'm kind of going with this.
No, 100%. This is my mantra. This is my mantra. This is why, You got
Nobody wants to see me intubate them where I'm when I'm like in tears every single day.
you got to have your game face on.
I do. Well, because I know the next 2 months might be really hard.
Yeah, and so you could give your best care possible. It's like
absolutely.
This is why I always, try and stay on the positive tip and give that positive energy so we can stay productive. But I would say this, in terms of the modeling, the one thing I hope, and I'm not saying this is going to be a factor, but I'm hoping will be a factor, is that if we're not too far on that locomotive train, the fact that Christmas is now done, the fact that we're vaccinating our most vulnerable, I'm hoping that takes a dip into this, and the coyote might be out of the barn already, but certainly, I would hope that some of these subtle things can have an impact. I'm hoping.
So I think you have. I don't think you have unintended positivity. I think your positivity in the context of the way things are lining up with respect to vaccinations is. I hope you're right, and I'll tell you why. Because I think come mid-February, perhaps. The way I kind of read the tea leaves with regards to vaccination, if we can get most high risk long-term care, this is where 75% of the deaths are within Ontario, right?
Yeah.
If we can get, I'm talking about congregate living centers and the whole bit. If we can get high risk long-term care, retirement homes, if we can get everybody vaccinated in that construct, if you look at the vaccines, they really start working first dose. I don't want to get into a lot of specifics, but first dose starts working around 10 to 12 days, right? And my suspicion is you're going to get very, 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 very little bit of severe disease after that, right? Second dose comes in, you get an efficacy at 7 days later in the studies of like 95% with both messenger RNA vaccines, right? If you can take the population that ends up in, like, not just in hospital, but mortality wise, right? Because we know a lot of patients with their predetermined goals of care who are in nursing homes, long-term care homes, don't want to be transferred to hospitals. Some of them are in a stage of their life where legitimately, if something significant like COVID happens, and they get respiratory failure, they don't want to be intubated and end up in an ICU, and that we have to respect. I think in the context of biggest bang for your buck with that is to vaccinate all our loved ones in long-term care homes. That brings the mortality and the morbidity of the disease down. Are we going to see people in their 50s, 60s, 70s, 40s, 30s, maybe in the ICU? Yeah, but statistically less and less and less. So I think what's going to happen is, winter, right? Winter is hitting all of the northern hemisphere hard. I don't think you have to look at just variants. I think just the fact that September came around was an eye-opener to a lot of people who felt that they were out of the woods, right? And then now that we have vaccinations, thank goodness, we thought vaccinations might never come, right? Remember those kind of, conversations that we had. So we have to also kind of look at things and say, yeah, we're lucky. This is 1 year. Pharma's come to our rescue, awesome. Right? And the combination of that, the combination of, the effect of limiting interactions at this point in time with governmental actions, and the fact that March and April are coming, I think are going to, hopefully, I think we're going to see our peak of morbidity, mortality in February. I don't think we're going to see our peak in March. Now with the variant, who knows? But I also think that weather plays a huge behavioral role, and likely a biological one too. But I'll let the smarter biologists and virologists weigh in on that.
Well, even more reason for the vaccine too. If we do get more of the variant that seem to be more contagious.
Absolutely.
But from early studies show that the vaccines should be able to combat the new variant. So
Yeah, and we have to be careful, right? Like, this is the one thing. We have to be careful because we've never studied a virus like this one, right? So, like, it's not also psychologically helpful to think that every single time somebody's going to put out a variant, that the vaccine's not going to work, right?
Yeah.
I think people have to be, because we have to go under the notion that the vaccine is going to work. And every study, I just saw neutralization titer assays that were done with the B117 variant and the variant from South Africa, and they're fine. They work just fine. So, just reading virologists, the vast majority think that it's going to take years to have mutations that are going to bypass natural immunity or vaccine-related immunity that we have now with messenger RNA vaccines. Or with the recombinant protein ones that hopefully are coming down. But the reality is that I think it's also dangerous mentally to think that every single time you read a newspaper article, you're going to think, oh my God, if I got vaccinated, it's not going to work.
Well, when you got the premier going on saying this new deadly strain is coming at you, like it's not helping, dog. It ain't helping. Listen, let me thank you for making this happen. This is very therapeutic for me. This was a bit selfish because to me, it was just a very frustrating day, knowing that, we were going into further restrictions and not getting to root causes. Not really.
Is there a billing code for this?
Yeah, it's no, I'm just kidding. But listen, no, I really appreciate this because, like the thing and we've said this before, the thing I appreciate is, believe it or not, people, we disagree with a reasonable amount of stuff, but we agree to have it in a civil manner. We'll agree to disagree at different times, and we embrace being able to have that dialogue is what we need. And this is what we need in medicine. This is what we need in society to move forward. Honest discussions. You know what I'm saying?
Can I say something about that?
Yeah.
You have time?
Yeah.
So one of the things that I've seen on social media, right? Because I think this is our biggest problem in society, in my opinion, right now, with regards to civil cohesion and stuff like that, is that, what's happening right now with even, there's advocacy, which I commend, right? I think advocacy is important, but I think empathy and scientific discussion is also important. And I think we have to set ourselves apart with regards to, like, you and I are friends, but we do have significant disagreements, right? Like, I don't see modeling perhaps as like you do. Like, I actually think this lockdown might work. I understand the notion of, marginalized community. I mean, I fight for that. Like, I not as much as, a Dr. Turnbull would or what have you. They're just, incredible at that. But I have a lot of empathy for these kind of situations, and I recognize them as the main issue in this situation. That being said, I respect your opinion, and I see the good that you've been doing in a lot of different ways. What we're missing right now in medicine, in my opinion, when it comes to COVID, is that advocacy sometimes becomes legitimate siloing. And so when somebody else, for example, might say, kids in school, when somebody brings up the fact that a child who comes from a situation that they live in poverty, right, may never, if this continues for 2 years, I mean, who knows, right? Like, if we didn't have a vaccine, might never be able to take the same steps as somebody who lives in a middle income, or can do pods like in the US, or can have a Mac at home and have great Wi-Fi and a parent who can help them through school. If we can't have that discussion and say there are risks and benefits to policy decisions we make, right? And they don't all have to be counted with a COVID lens, right? That sometimes we can say, look, there's a lot of kids who are going to have child abuse. There's a lot of kids who are going to have issues with regards to furthering their education, which actually does cause problems in their life afterwards. They're just not going to be able, statisticians right now are not going to be able to measure that right now, but we will be able to measure increased cancer deaths 2 years from now or 3 years from now, or decreased ability to get good employment, 10 years from now. And I'm not saying I have the answers to that, but we should be able to talk to one another about that rather than kind of block and say, okay, this, and then, okay, I don't want to talk to you anymore, and those kind of things. And this is what's happening, I think, in the sphere of these discussions, where I feel people are kind of siloing each other. And that, to me, as a scientist and as somebody who's tried to keep an open mind to everything, hurts. And I make no apology for that. I think if I disagree with somebody, I haven't been perfect at it, but I try my best, and I'll apologize if I ever siloed anyone because of that.
Reach. And like, how many times have we all been wrong? You know what I mean? Humbled in real life, and when it comes to COVID, when it comes to so we got to stay humble, we got to stay open-minded, and we got to have that ability to have dialogue and not be siloed. That was a perfect way to end this bad boy. Thank you, everybody. I'm doing a proper outro here because we're gonna post this. I'm gonna try and post it for tomorrow, actually. And so if you dig what you've been doing on the show, leave a rating on iTunes or Spotify. It helps with the visibility of the show. Comments at quadcast99@gmail.com. Follow us on Facebook, Instagram, YouTube. We love hearing from you, and we're going to continue to change that boogie. You know what I'm saying? Advocate for those that can't advocate for themselves, and just, continue that dialogue and transforming healthcare for real. You know what I'm saying? You know what I'm saying, TP?
Oh, I know. Hey, and I told you, did you notice my daughter put a mask on Grogu?
I was all over that the whole time. That's who I've been eyeing the whole time. It's actually quite funny.
He's eyeing you.
May the force be with thy.
Yeah, sure.
Did I get that right?
Yeah. You, thy.
Thy. All right, guys.